my time. Yesterday we talked about sonal anatomy of reading the abdominal regions, and now we are going to see what can we do for the disease abdomen. Today I would like to focus on those with limited practice, limited experience, and focused one, but has great impact for our clinical practice. I think that's the starting point for us to use the ultrasound to answer some of the disease abdomen questions. The first one, this kind of stool, you would not like to see in the pediatric patients, right? If you see this kind of stool, the patient's condition is definitely sad. So let's take a look at these kind of conditions. The most common type of the intussusceptions is ileocholic type. So the ileum telescoped into the ascending colon. That's the most common type intussusception we will identify, and that is the locations the intestine will be pulled up to the right upper abdomen, and we all know the pathophysiology. The telescope into the other intestine or colon, then will obstruct some of the blood flow. Then, when the time lasts for longer time, can cause edema, strangulation, or even ischemia, and the worst situation is death. But for the pediatric patients, if they are not verbal, cannot express by themselves, such as 1-year-old girl, she can only express by irritable crying. So in my department, our residency or ourselves to visit the pediatric patients, if that is an irritable one, we will use ultrasound as our screening tool. Then we can see that traditional, we can take the X-ray to see what's going on. Luckily, we have a typical one, right? Like this one. But actually, you cannot diagnose intussusception based on the radiography. So myself, I do not take the X-ray because nonsense. But if I'm trying to look at others, such as bowel obstruction, free air, I will take the X-ray for that kind of purpose. Those names you can remember for to describe the sonographic signs of intussusception. Just like this one, looks like a target. Like this one, something like sandwich or half fork, or if that is a little bit oblique, looks like another kidney, but kidney is here, so it's kind of pseudo kidney. A lot of names to describe that. Crescent donut, double crescent. A lot of names, but describe the same thing. So let's look at these typical videos. The right upper quadrant, transversely, this is the kidney, spine, and the liver. And we can see it's kidney. What is this? The other one, right? So if you are trying to look for the intussusception, put your probe transversely on the right upper quadrant, transversely, and as long as you can identify the liver, kidney, look carefully over right there. And you can see the target and the sandwich, half fork, it doesn't matter. Depends on what you looks like, okay? So liver, kidney, transversely, and then after you find the target, find the lesion, you can change your direction of your probe. Sometimes we can find the leading point. Sometimes we cannot. In adult patients, normally we will find some leading point because of some pathology within the small bowel loops, or intestine. Like these patients we can compare the CAT scan and the sonography. That's what we learn ultrasound. Sometimes if you are inexperienced, you lack of those senior one to supervise you, but you have traditional way, CAT scan, X-ray, something like that, to diagnose the patient's conditions, you also want to learn the ultrasound, you can compare to the traditional imaging modality. Like this way, we can see this non-enhanced and enhanced one. The leading point is this one. So this is a sonographic finding of this leading point, hyperechoic, smooth, and without other shape. So based on this echogenicity, I would suspect that's kind of a fat component, maybe some lymphoma. But in adult patients, definitely need to get operated to prove is that benign or that is a malignant leading point. And this is a series of the CAT scan. The transection and the transversely, and at the leading point, and here we put the we use the transverse section here, can see the target and the sausage or sandwich-like appearance. So we have now the CAT scanned image in your brain. Now we look at the sonographic one transversely from the below, and then we can see this intestine transversely, telescope into the ascending column. Then move the probe transversely up. You can see this, and when we turn to the right side, all right, like this way, and we can see the leading point here. This is a transversely to move my probe from here to here. Then after identify this route, I will rotate my probe longitudinally to check this shape. So right now the target appear when I put my probe longitudinally to demonstrate this. Transversely move to here, and we can demonstrate this appearance of the interception. All right, so it doesn't matter where you can see the target or sandwich, but if you are trying to locate the bowel structures, I would suggest to move your probe transversely up and down to see the whole pace, and then to rotate your probe according to the pace to see two directions. And now we move to the other one. So the interception, I would suggest every emergency physicians and every pediatrician should acquire this technique to scan for this pathology. And then the second one will be appendicitis, because for the pediatric patients, normally it is not so obesity, right? Even if that is a fat guy or fat boy, it doesn't matter, because we can use an abdominal probe or linear probe to scan the abdomen. Even I can use the abdominal probe and linear probe to scan appendicitis in an adult patient. So it will be much easier to scan the pediatric appendicitis compared to the adult, right? So we all know the pathologies of the appendix. The clinical presentation may got the right lower quadrant pain, may got fever, may got leukocytosis. We all know that initially it will present as gastric pain, periumbilical, visceral pain, and then migrate to the right lower quadrant to become a peritoneal one. So the first thing, we talked about the sonor anatomy yesterday. Now we look at this comparison. Initially, if you are trying to identify the appendix, trying to identify the anatomy you will definitely find in every patient, every scanning. So put the probe transversely, we will see the iliac crest, the psoas muscle, the iliac vessel. Where is appendix? Appendix could be pelvis, could be typical location, could be retroperitoneal, and could be laterally. So move your probe based on this landmark and slide to the pelvis, slide to the upper part based on the patient's clinical presentation. Because when you gradually compress the probe, the patient's most hurting area definitely tells something, just like this one. The anatomy comparison, the iliac vessel, and this is the appendix here, right here. This video is scanned by my fellowship. So this kind of competence test, when he scanned this and recorded it, I review, after maybe 1 day, 2 days later, I can make sure that he can scan this kind of pathology. The other one, 9-year-old boy, got abdominal pain maybe for 2 to 3 days, and today they developed dysuria. And this boy is quite interesting because he got the abdominal scan, the one previous to the ER visit by the GI, pediatric GI doctors, because the pediatricians in the outpatient department suspect these patients may have appendicitis, so got the scanning by the pediatric GI doctors, and turned out told to have enteritis only, and just need to observation. The next morning, patients come in. Not this one. Okay, and then complaint dysuria. So my colleagues asked me to scan what is going on in the pelvis and if the patients develop appendicitis. So let's see what's going on. What ultrasound tell us about the patient's story? The patients develop dysuria. What caused the dysuria? It is the transverse scan of the bladder. Do you see the ascites? Ascites, right? Bladder ascites transversely, and then move sexually. Bladder ascites. So that kind of fluid irritated the patient's bladder, so cause the symptom. Where is the bladder? Where is the fluid comes from? I scan from the right lower abdominal. See, these tubular structures, direct evidence and indirect evidence. What is indirect evidence? Why is this so obviously? Because the inflamed mesenteric fat got brighter compared to normal status, right? So swollen got edematous, turned black, and then surrounded mesenteric fat got inflammation, so it turns brighter, hyperechoic compared to the normal appearance. So based on direct and indirect evidence, we can confirm that these patients got appendicitis. And this patient's appendicitis, when it looks under linear probe, looks like this way. Terminal ileum, lymph node. To here. And the margin is not so smooth. Here, we can also confirm that this patient got a rupture appendicitis, lymph node, the base, and then transversely to downward rupture site. Okay, so this is use linear probe. You can screen. Use abdominal probe. You can screen, but you want to find detailed information. You can shift to the linear probe. Can get you better resolutions and get you better evidence to make the diagnosis. And this boy's right abdominal pain much lateral compared to the traditional McBurney point to the right lateral. Why? Ultrasound can tell us like this way. Transversely, use the curved linear one, right? And then we scan the crest, spine, the source muscle. As you can see here, we can see a target even with a acoustic shadow inside that confirmed to be appendicolite. Use linear probe longitudinal from the base to right upper side. We can see that this appendix is a retrocecal one and got impact with an appendicolite inside the appendix. So these boys, we do not arrange the CT scan because in my department, after we confirm that, our surgeon and pediatric surgeon can accept our image because we provide excellent image for them to make the diagnosis, so we can skip a lot of CAT scan for our patients. Now, 14 years old boy with abdominal pain and vomiting, because pediatric patients got a lot of atypical presentation compared to adult patients. So after we meet this kind of complications, the problems, as you can see the traditional x-rays, got dilated small bowel loops, something wrong, right? It is. So we use the ultrasound to scan dilated loops. And then the most common type of this kind of ileus should be something wrong, and most commonly based on the rupture appendicitis. So typical locations: iliac crest, psoas muscle, iliac vessels, and then we scan transversely, and you can see this one, but without an end. Why? Because it is ruptured into the peritoneum. So you cannot find an end. You can find a blind-ended structures. You can find the base, and then downward is a lot of dirty fluid in the pelvis. So that's caused the patient's paralytic ileus here. And then this is all dilated. So we can see the peristalsis is limited and full with fluid and gas. So the patient is undergoing surgery, confirmed to be appendicitis rupture with paralytic ileus. But I would suggest that if based on this kind of conditions, maybe you need a CAT scan to confirm the other complications such as abscess like that, something like that. A young woman with right lower quadrant pain. This is the patient's appendix. The appendix looks a little bit larger than normal. The diameter, the maximum diameter, is about 6 to 7 millimeters century. So based on this criteria, I should diagnose this patient has appendicitis. But interestingly, I use the probe to compress this lesion. The patients do not have any, she doesn't feel any pain. So would you confirm that is appendicitis? Definitely no, right? So we have to see this kind of pathologic finding and to correlate with the patient's clinical presentation. Where is the hurting area? The hurting area is here. What is this? When I move the probe upside down, and I can see this solitary appearance, a black node, that's a lymph node. So the patient's pain, the hurting area is here instead of these regions. So sometimes we can see abnormally dilated appendix because of reactive change to maybe enteritis or something, PID like that. That is a reactive reaction, not actually appendicitis. Because we can see the structure around the appendix is quite clear compared to those kind of hyperechoic mesentery fat in the previous videos. 5 years old girl also got right abdominal pain. We can see this kind of lymph node, solitary. So how to compare the lymph node to the vessels without Doppler? You just scan by the path. The vessels you can track, but the lymph node should appear solitary, right? So lymph node here, and the other one is an upper one. Bowel obstructions. The X-ray is typical without problem, right? How about this X-ray? The patient's got the abdominal pain and vomiting. Can we interpret this X-ray as bowel obstruction? Difficult, right? But sometimes because of the X-ray conditions, sometimes you need to do it standing X-ray instead of KUB, right? This kind of X-ray, we cannot diagnose it as bowel obstruction, but the X-ray, the ultrasound of these patients, we can see dilated small bowel loops compared to the X-ray. The transversely, the sagittally, and we can also see some ascites, minimal ascites around the small bowel loops here. This is dilated small bowel loops. We can find some collapsed bowel loops in the regions far away. So this patient's got abdominal surgery previously, so we can diagnose that this patient may have adhesion ileus. It is not so common to find the adhesion band here, a fibrotic band here, to cause this problem. So it is not a common and routine procedure to find that. But this kind of findings, dilated bowel loops, is quite easy to identify using the ultrasound, especially for those gasless ileus. Remember that, because the typical one, full with gas, you can diagnose easily on the X-ray, but the gasless abdomen, quite more severe compared to a traditional one, is much better to diagnose using the ultrasound. Then we move to the pylorus. We know the pyloric mimics got a lot of criteria that make you to remember these conditions. Peristalsis visible sometimes, right? And sometimes got non-biocontent vomiters, and the diagnosis is based on the ultrasound. So this is the typical one. Typical one. If the pyloric stenosis and got obstruction, so the fluid content will be obstructed. That kind of obstruction can create a window because that obstruction will contain a lot of fluid, so make the contrast better to see the pyloric structures. This is the pyloric. So what is the diagnosis criteria? We can measure the wall thickness, 3 millimeter. We can measure the length. We can measure the whole thickness. So the criteria, I think we should remember that 3 millimeters and 15 millimeters of the length and the muscular thickness. We see 2 video clips of this typical one. The dilated gastric content, and you can see this pylorus. We can measure the thickness or measure the length. The other one, the content of the stomach can pass through this narrowing lumen, right? So measure the length or measure the thickness of the muscular wall. Then to the gallbladder. Acute cholecystitis has a lot of diagnosis criteria. One of the criteria is gallbladder wall thickening, but these conditions can also cause the gallbladder wall thickening. So I will not recommend you to diagnose appendicitis based only on wall thickening. Instead, most of the time, we can find gallstones and edematous of the gallbladder, and if it is possible, best to plot the positive echo Murphy sign. Then we can diagnose acute cholecystitis. This is associated findings you can observe: the fluid around or intraluminal air. The measurement should measure in the anterior face for the gallbladder wall thickening. For the diameter of the bile duct, we should measure the inner side, inner lumen, instead of outer lumen. So the diagnostic criteria for pediatric 3 and 6, if the diameter is more than this value, it should consider abnormal. So maybe we look quickly because we got limited time. The gallstone here and the patient's echo Murphy sign cannot demonstrate on video based on your practice, all right? Okay. And here we can also see the polyp there. Can you see the gallbladder? Right? The gallbladder is full with sludge and stones, so we even call it as wall echo shadow. The wall, a minimal fluid and a lot of stone, wall echo shadow. That's kind of diagnosis you will be missed if you not look carefully. And this one, portal vein, but common bile duct. Multiple layering would be much specific for acute cholecystitis instead of wall thickening. As you can see, the gallbladder wall is multiple layer, even with the sludges inside. Then if we are looking for the common bile duct, gallbladder direct to portal vein, and then the tube lying above is the common bile duct, and you can trace to the distal end to find something if you are lucky enough. And this is another video clips. The sandwich, the circle inside is the hepatic artery. As you can see, dilated common bile duct. What is this? A lesion inside the left lobe, right? Hypoechoic or mixed echoic. So if the patient's got fever leukocytosis, we will diagnose it as liver abscess. For the kidney obstruction, we can see clearly the stone here. So if you scan the kidney based if you are trying to find the obstructive uropathy, scan both sides and the kidney, both sides of the kidney and the urinary bladder. The right side and left side, we can see the hyperechoic with acoustic shadow. Sometimes you see direct evidence, sometimes you see indirect evidence. Indirect evidence is the dilated calyx. The direct evidence is the hyperechoic one. The indirect evidence is the shadow, because sometimes the stone is too tiny to observe, so I can only find the indirect evidence, then look upward to find the direct evidence. The normal one, the abnormal one. So if you are trying to look for the obstruction, you can scan from the coronary view and then shift to the transversely and to see spine, outer IVC, and because the urethra down to the leg, so you have to move transversely. This is a girl with flank pain, fever, leukocytosis. What do we see? The bladder, right? What is within the bladder? A bladder and a cystic-like component here, and also got echogenic content inside, right? So what is this? Urethral seal. So the patient's got double urethra and urethral seal, so quite uncommon in adult patients, but sometimes you will observe and detect it in the pediatric patients here, right? Easy, right? Hyperechoic acoustic shadow, so it's renal stone. And how about this? Dilated, right? But the echogenicity inside is increased, hyperechoic content within. So the patient's got pyelonephrosis. The pyelonephrosis because of this obstruction, indirect to the direct one. And the patients, sometimes we can see dilated urethra. But if you are trying to locate the obstruction site, you can see the UPJ, iliac vessel region, or even the urinary vesicle junction here. You can find stone obstructed here. And if we are trying to confirm if that is obstruction, we use the Doppler to see if there is Doppler urinary jet. That means the patients may not have complete obstruction. Because I run out of time, so I will move quickly to the last two case. This one, what do you see? Squirted. So I would also recommend if you've got linear one with Doppler functions, the patient's got swollen testicles, you have to scan that. This one got swollen without flow. The patient's got testicular torsion. That's kind of emergency. Fluid. And transversely, for the teenage girl, rupture ovarian cyst. But first one is to confirm nothing inside, to check the pregnancy status, then make the diagnosis. Okay.